Welcome, everyone. We're about to begin our webinar, and the title of the webinar today is Activities in the Healthcare Setting for Secondary Prevention of Childhood Obesity. So this is one in our series of webinars on the Childhood Obesity Research Demonstration, or CHORD project. So I'm Deanna Helscher, and I'd like to welcome you all to the webinar. Today with me on the webinar will be Carrie Doima from Centers for Disease Control and Prevention. Also, our speakers today will be Sarah Barlow, who's an MD, MPH, and Professor of Pediatrics at University of Texas Southwestern Medical Center. And then Nancy Butte, PhD, who's Professor of Pediatrics and Nutrition at Baylor College of Medicine. So they will be describing some of the CHORD secondary prevention results. And so now we'd like to proceed with a little introduction on CHORD that Carrie Doima will be presenting. Carrie?
Hi, good afternoon. Thanks everyone for joining. I'm just going to provide a quick overview of the CHORD project in its whole before we go down into the secondary interventions presented today. I'd like to just acknowledge I represent a team of folks here at CDC spending time and working on the CHORD 1.0 project. Next slide. So just to give you a little sense of CDC and the division that this project came out of, we're in the Division of Nutrition, Physical Activity, and Obesity. And you can see our strategic priority areas to really support all Americans across the lifespan to achieve proper nutrition and physical activity. You can see the little star. So most of our CHORD work falls into childhood obesity management and the various settings that children interact with to help them grow up strong and healthy. Next slide. So I'm sure many of you are familiar with the statistics related to childhood obesity, but I'll just highlight a few, including 17% of children 6 to 11 years old with obesity, and 5.6% of them have severe obesity. We know obesity tracks from childhood into adulthood, impacting both physical and mental health, and is having consequences for our nation, with nearly 1 in 4 young adults unfit or too heavy to serve in the military. Obesity is very costly also. Next slide. So many of the pieces of CHORD that you'll hear about today really do rest on the recommendations of the Institute of Medicine, formerly now the National Academy of Medicine, thinking about taking action in multiple settings where children live, learn, and play. We also have the 2010 American Academy of Pediatrics Practice Guidelines for the Care of Children, and the 2017 USPSTF recs that recommend that providers screen all children 6 and older for obesity and refer or provide lifestyle modification programs. Next slide. CHORD 1 really was the foundation. So you can see here in the middle, we really required a multi-sectoral approach and wanted to focus on reducing obesity through increasing nutrition, adequate sleep, physical activity, vegetables, and decreasing some of those behaviors such as screen time and the consumption of sugary drinks and energy-dense foods. The target audience were low-income children, ages 2 to 12, and grantees needed to apply evidence-based interventions in these settings, so the child care setting, school setting, and the healthcare setting, which we'll discuss today. The most important part of this slide are the grantees located in the yellow box, which were the University of Texas, San Diego State University, the Massachusetts Department of Health, and the University of Houston as the evaluation center. Next slide. This is just a schematic of kind of what I outlined earlier about interventions in the multiple settings represented by the different colors, really trying to impact the systems in which children are a part of, but also the education and social support of families. Next slide. Cord 1 was a prevention and a treatment model, and really tapped into this collective approach using community coalitions, really trying to make that community clinical linkages and honing in on those key organizations who were able to implement evidence-based practices. As far as interventions in the healthcare setting, we know it's a very important setting to both prevent and manage childhood obesity. And we also know that healthcare can be a prime opportunity to screen and counsel all children, but then also, which you'll hear about today, that referral into programs for children who need them. Cord researchers, really, we did think about the sustainability of Cord interventions and embedded things like clinical decision supports, which aid providers to provide optimal care. Lots of training and technical assistance was provided to healthcare providers to really improve their skills and knowledge and help families. And finally, there was a referral venue for children and families with obesity. Next slide. So we're really delighted to have this opportunity to learn about the secondary interventions and how children got into those secondary interventions from the following speakers. If you want more information on Cord, please visit our website. There's also resources such as publications and toolkits. I'll turn it back over. Thank you.
Okay, now we'll have Dr. Barlow, who will talk about recruitment strategies and outcomes for weight management. Dr. Barlow?
Great, thank you. So I'm really the prequel for Dr. Butte, and what I want to talk about is how we get to the actual enrollment so that when we're studying interventions, we understand not only what happens to the people that participate, but who didn't participate. Next slide. So this is the schematic that if you've been on other webinars, you will have seen before for our Texas Cord. The outside circle shows our primary prevention locations, including elementary schools, child care centers, primary health care, and some government and public policy training. And then the inside circle is our secondary prevention. And our secondary prevention was a study, a randomized controlled trial, looking at, in one arm, an intensive intervention based in YMCA centers, and in the other arm, a healthcare-based, less intensive intervention. So we're really focusing on that healthcare piece, the primary healthcare, and then the secondary prevention. And this is important because the eligibility for that secondary prevention was limited to patients who were being seen in our primary health care. So that red arrow represents that. Next slide. We were charged with identifying catchment areas that were focused on lower income areas in our cities. So I've outlined here the catchment area in Austin and in Houston, and these were selected based on census data looking at household income, education, race, and ethnicity. So within those catchment areas, we identified healthcare offices who were serving primarily children with Medicaid and CHIP or Medicaid and CHIP eligible. Next slide. So on the right-hand side of this slide is really the focus of Dr. Butte's presentation, which is the randomized controlled trial of those two arms, the intensive community arm and then the office-based care. And what I want to talk about ahead of time is what's in green. Who were those eligible patients in practices? What were their characteristics among those who was referred and among those who enrolled? Next slide. So this is kind of the theoretical structure. We wanted to identify all patients ages 2 to 12 years, which was the target of our intervention, seen during our recruitment period for that randomized controlled trial. Understand their characteristics, and then look at those who had a BMI above the 85th percentile, which was the criteria, or one of the most important criteria for participation in the study. And then of those, some subset were referred. They had interest in the study, and then of those, some enrolled. Next. So what we did in the primary care practices had multiple purposes. One, it was part of our primary prevention to encourage obesity recognition and care, but doing that also provided a way to optimize referral and study enrollment. So again, I think some of you who were on other webinars may have seen this, but we provided some training for physicians and support staff, both in person and online, whatever they preferred. And the components that we used, again, both to provide a process for care of obesity, but also to help assist in recognizing obesity and making referrals to the study. And that included some electronic health record tools, including a best practice alert, which you'll see on the top right, a yellow flag that comes up when the child is seen in that age group with a high BMI, that offers the option of choosing a smart set, which in this particular electronic health record is a way of presenting the most likely tools such as diagnostic codes, referrals, laboratory that one would use as a physician if you were evaluating a child who had overweight or obesity. We also, within that smart set, embedded a link to the study so that there was a really easy way for providers during that visit, if the family expressed interest in the study, of making that referral. And then we also had our counseling guides in the form of Next Steps, which is a set of material that provides themes around healthy eating and physical activity, with and support for that, so that providers can briefly help families choose one or two themes and provide counseling within the context of a busy visit. Next slide. So the practices in our catchment area included 5 practices in Houston. Those practices all came from a single large hospital network. 3 of them were really structured as medical homes for low-income patients, and the other 2 had a combination of commercial and public insurance. They all had the same electronic health record, and so we were able to implement that alert and referral that I just spoke about. In Austin, there were 7 practices from 3 different organizations. They were either federally qualified health centers or safety net clinics. There were 3 different administrations and therefore 3 different electronic health records. And there were some administrative changes, so we were not able to actually implement alert or that internal referral in Austin. Next slide. So, but everybody had electronic health records, and so these organizations provided us with de-identified data on the patients that were seen in these offices that were ages 2 to 12 during our recruitment period, which was September of 2012 to January of 2014. And in our study, as Dr. Butte will tell you, we were stratified in 3 different age groups, 2 to 5, 6 to 8, and 9 to 12. And so all the data I present will be presented in that way. So you can see that there were over 13,000 2 to 5-year-olds who were seen during this time period, and about 7,000 6 to 8-year-olds, and about 7,000 9 to 12-year-olds. Next. Oh, can you go back? There should be a highlighter embedded in that. Does that work? Nope. Okay, never mind. It's okay. So the race ethnicity, you can see that about 60% were Hispanic, about 20% were Black non-Hispanic, and the rest were predominantly white, as well as some others. And about 75% across the board had Medicaid or CHIP. And then if you look at the BMI category distribution, you'll see that if you look at the 85th to 95th percentile, you know, it goes up from 13% in the 2 to 5 up to 19% in the 9 to 12. The kind of standard obesity range, 95th to 99th, went from 7% to 21%, and the greater than the 99th was around 5%. And when we compared these numbers with contemporaneous NHANES data, when you looked at it within the appropriate racial ethnic groups, it was pretty similar to national prevalence. Next. Okay, and so here's the actual data that we got. So there were 26,000, almost 27,000 patients who were seen during this time period. Of those, 29% had a BMI above the 85th percentile. And of those, 27% were referred. So referred families heard about the study and agreed to receive more information. And then of those referred, 26% enrolled. So if you look at all the children with above the 85th percentile, ended up being 7% who actually enrolled in the study. Next slide. Okay, actually here's where my highlights come in. So just to orient you, I have, we're looking at 3 different levels here within the 3 different age groups. So within 2 to 5, I'm showing you the data on all the children who were seen that had a BMI above the 85th percentile. That's office greater than the 85th. The middle column is those who were referred, and the last column within each age group is those enrolled. And we have data that includes age and BMI for everything. We do not have race, ethnicity, or insurance on the referred. Next. Okay, perfect. Okay, so just to look at how the characteristics differed across these different levels of engagement, you can see that the proportion who enrolled was close to, it was 85 to 90% across the different age ranges, which was more than the proportion of children above the 85th percentile. So it seems that Hispanic families were more likely to enroll. Next. Similarly, the Medicaid and CHIP group, the proportion was higher among those enrolled compared to those above the 85th percentile. Next. And then looking at the BMI category, you can see that especially the percent who were in that highest BMI category above the 99th, next, the proportion who were referred was about twice of that who were above the 85th percentile across the board. And then when you look at the 6 to 8-year-olds, there was very little difference between the high, those with severe obesity in the referred group versus enrolled. So in other words, having a high BMI was associated with referral, but once referred, that BMI level was not an association with enrollment, suggesting there were other factors that led to enrollment. Next. And then finally, there were some differences in the age groups in this process. So about 30% of the 2 to 5-year-olds were referred, but only 20% of them actually got enrolled. Whereas in the 6 to 8 years, 23 to 25% were enrolled, but a third of, were referred, and about a third of them enrolled. So it was much harder to actually encourage the families with younger children to enroll. And actually that referred number is reflects the additional efforts that we had to go through in order to identify families to enroll. Next. And this is showing similar data in a different way, the 3 different age groups. The blue section shows the percentage who were not interested or not responsive after referral. And you can see it's much higher in the 2 to 5 than in the 9 to 12. And that really kind of complements the enrolled percentage, which was only 20% in the 2 to 5 versus about a third in the 6 to 8 and 9 to 12. And those who didn't reach research criteria or didn't have medical criteria were pretty similar across the 3 ages. Next. And finally, we look to see what the rates of referral and enrollment looks like by practice. So this graph shows the 12 practices that we worked with. The denominator are those the 2 to 12 who were above the 85th percentile and potentially would be eligible. And you can see that the referral rates range from a high of 69% down to a low of 9%. And when you looked at enrollment rates, which, as I told you, was overall 7% of the total population, it ranged from a high of 26% to a low of 2%. Next. And before you move on, so the asterisk ones showed those offices in Houston that had EHR alert and therefore a referral link. And we actually did not find any relationship between having that and rates of referral or enrollment. Next. So in summary, we did have a racially and ethnically diverse population and low income. The overall referral rate was 30%, with the 25% referred for an overall enrollment of 7%. We struggled with the families of younger children. As I said, severe obesity was associated with referral, but not with the movement from referral to enrollment. And there was this high variation in referral and enrollment by practice without association with those EHR tools. And finally, next slide. So I think the future directions are that we really need to make sure that we study this area, because when we have effective programs, we have to make sure they're adopted in order to have an impact on the obesity epidemic. And I think we need to explore the barriers to referral and enrollment at the family level, but also the barriers to referral at the practice level, and explore the reasons for that variation. And I will stop there. Thank you.
Thank you, Dr. Barlow. We're now going to transition to talking about the Texas Court's secondary intervention and talk about our methods and results. And with that, I'll hand it over to Dr. Butte.
Good afternoon, everybody. It's my pleasure to present to you the results from the secondary intervention that Dr. Barlow has just introduced to you. And before I start, I just want to bring to your attention a recent publication that appeared in Obesity this year that describes our full RCT, all the methodology and the results in full. So the overall study aims of the Texas Court project were, number one, to evaluate the primary prevention obesity program in low-income, ethnically diverse catchment areas in Austin and Houston, as Dr. Barlow showed you. The secondary intervention was to evaluate a 12-month family-based secondary prevention program within the community primary prevention program. We hypothesized that a 12-month community-centered program would significantly reduce BMI compared to the primary care-centered program in low-income, ethnically diverse, overweight, and obese children, ages 2 to 12 years of age. Specifically, we wanted to determine the comparative efficacy of a 12-month community-centered program, which I'll refer to as the intervention, against the primary care center program, which I'll refer to as the comparison. And that's the program that Dr. Barlow has just described to you. So it's really important to keep in mind that our RCT was comparing two programs. It wasn't a do-nothing control. We actually had two programs in place. Our primary outcome was BMI expressed as a percentage of the percentile, BMI percentile at the 95th. We had several secondary outcomes, and today I'll present the outcomes in terms of body composition, blood pressure, and psychosocial status, which were measured at 3 and 12 months post-baseline. Next. Our study design called for 576 children who were overweight or obese, ages 2 to 12. They were randomly assigned to either of the two programs, the intervention or the comparison, stratified by the age groups 2 to 5, 6 to 8, and 9 to 12. The RCT was, again, conducted within that primary prevention catchment areas in Austin and Houston. And the family allocation was over the period spanning from 2012 to 2015 and consisted of 5 different cohorts. Again, the comparison that was centered in the healthcare clinics, and Dr. Barlow has presented you the components of that program. I'd also like to point out that this program is really self-paced. The family was introduced to the next step materials, and it was really up to the family and the physician to set follow-up visits. The community center program was clearly more intense. It was conducted at the YMCA. There was a large staff in place at each of the YMCAs. Theory leaders, community health workers, and exercise leaders actually carried out the intervention. The program was really 2 levels. There was one program designed for the preschool age group, the 2 to 5-year-olds, and the school age group, 6 to 12. We'll be presenting the results stratified in the 2 age groups, 6 to 8 and 9 to 12, but I want to point it out that the program was the same. It was just delivered at these specific age groups, 6 to 8, separately from the 9 to 12-year-old children. So the preschool program is a program called MEN 2 to 5. The school-age children and their caretakers, their principal caretakers, receive the MEN 6 to 8 and 9 to 12 program. In addition, we use the catch exercise sessions as well as YMCA sports teams to provide exercise opportunity for the kids. There were support materials online for the MEN program, as well as other printed materials. Family support in the transition follow-up period consisted of MEN refreshers, the Be Well book, as well as cooking classes and text messaging. And this graph basically sort of shows you graphically a breakdown of the program. The first 3 months were quite intensive, with the follow-up period, which we refer to as the transition period, from 3 to 12 months. The preschoolers, by design, the program was less intense. So the MEN program was delivered at 1.5-hour sessions once a week over the 3 months, and the follow-up consisted of a 1.5-hour session once a month. The older children received the MEN Catch program, which was a pretty intensive 2-hour session twice a week for the first 3 months. The follow-up period, the families were offered YMCA youth sports for all the children. Those are given 1 hour twice a week, and the family support classes were offered once a month, consisting of the components as you see on the slide. Next. For those of you who aren't familiar with the MEN program, this is a behavioral modification program for overweight and obese children that was developed in the UK. And MEN stands for Mind, Exercise, Nutrition, and Do It. The various components are displayed here. It's a very comprehensive behavioral modification program to instill healthy nutrition amongst these families, provide exercise opportunity for the children, and the tools and actually to enact these changes. Next. And on these next slides, I just have a few photos of the program in action. In the older children, the 2-hour session was divided. The first hour was more of a didactic program delivered to the child and the parent. And so that was at the level of the child. The follow-up hour, the children went off to the gym for the exercise, where the parents stayed behind with a more adult discussion with the theory leader. Next. Here's a few photos of the exercise sessions in action. We drew from the CATCH program different exercises that were appropriate for overweight and obese children. Very importantly, the types of exercise chosen were intended to be fun, but at the same time to promote fitness in these overweight children. In the transition period, the support sessions brought in cooking classes, which were very popular with the families, here shown on the left, as well as many activities for the children to help to encourage continuation of the aims that were introduced in the first 3 months. Our outcome measures, the primary outcome was BMI, again expressed as a percent of the 95th percentile. The secondary outcomes included fat mass measured by BIA, blood pressure, fitness using a step test, physical activity, diet was assessed, as well as psychosocial outlook. We included the PEDS quality of life questionnaire, as well as the strengths and difficulty questionnaire. Next. The data analysis was subjected to a multi-level mixed effects linear regression analyzed by the 3 age groups separately. We did an intent to treat analysis using multiple imputation, as well as perform sensitivity analysis using maximum likelihood estimation, as well as complete cases analysis. A secondary analysis was performed for the intervention group only to look at the effect of program compliance on the outcomes. This slide, very small, I apologize, but it's really our Consort diagram. And the important takeaway messages here are that at baseline, as Sarah showed you in detail, we had a 26% enrollment of the referred children. At 3 months, we had retention of 76% in the intervention group and 79% in the comparison group. And at the 12-month measurement point, we had comparable 68% in the intervention and 82% in the measured group. This slide shows the baseline demographics of the families that were enrolled. And again, Sarah went into this in great detail. We had a good balance between boys and girls. Our study was predominantly Hispanic, as you can see here, with a small percentage of Black families. Annual income, as you can see, 75 to 80% of the families had income averaging $25,000 or less. So again, low-income families. And the educational level of the parents was, again, around 60, 75% less than at 12 years or a high school education. And here are the baseline characteristics of the children themselves. And I'd like you to focus on that percent of the BMI at the 95th percentile. And you can see that the averages were 10%, 13%, 16%, 20% above the 95th percentile. And to help you put that in perspective, the 120th percent would be equivalent approximately the 97th percentile, which you might be more familiar with. So of the children enrolled, we really did have a high percentage of children that were severely obese. 82% of the children were obese, with about 18% overweight. But of the children who were obese, about 70% of the children were above the 97th percentile. The blood pressures are shown here, as well as the psychosocial status of the children at baseline. And again, of those who are familiar with the PEDS quality of life score, these are actually, on average, fairly high. Next. And this is our primary outcome. Again, the percent of the BMI at the 95th percentile. We'll look first at the preschoolers, age group 2 to 5 years of age. In this age group, we did not encounter a significant group by time interaction, which indicates that we did not see a significant difference between the efficacy of these two programs. The asterisk is actually showing you the time effect. And so you can see we had a significant decline in the percent of the 95th percentile in the intervention group in the first 3 months. In both groups, in the follow-up period, the follow-up 9 months, we saw a rebound. You go down to the age group 6 to 8 years of age. The blue arrow is to remind me that we did have a significant interaction which indicated that the intervention program had a greater efficacy than the Next Steps program in decreasing the BMI status of the children. Also, you can see the significant time effect shown in the intervention group, as well as, unfortunately, the rebound in the transition period. In the 9 to 12 years group, we had a borderline interaction at the p equal to 0.07. So it was not statistically significant, but certainly there was some hint that there was more going on in the intervention group than the comparison group, which actually seemed consistent with the significant time effect here shown, the significant change from baseline to 3 months in the intervention group with less of effect in the comparison group. Here in the transition period, we did not see a significant rebound or a significant time effect, which is somewhat encouraging because, as many of you who work in this area, without attention, these children tend to gain more weight. Next slide. We looked very carefully at the dosage and at the effect on the outcomes. In the comparison group, as I said earlier, it really was up to the family and the physician to set follow-up visits. But we estimated that in that first 3 months, it would have been reasonable for the families to have had 2 follow-up visits. However, as you can see, the percentage that families that received this was quite low, only down about 10%. We look at the intervention. Here, the number of sessions was very formalized by the program. In the preschool program, we offered 9 sessions, and in the older children, a total of 18 sessions were offered in the first 3 months. So you can see here that on average, the percentage attendance was 46%, 58%, and 47%. So we were very interested in trying to see if the families that attended more sessions was the outcome better. And this is shown in the following figures. First, we'll look at the preschool group. And the slide on your left is showing the results for the first 3 months from baseline to time 2 at 3 months. And you can see what this slide indicates, that in families that attended greater than 70% of the sessions, there was a significant decline in the percent of the 95th BMI percentile. In the next 9 months, in the transition period shown here on the right, there was no significant relationship. And next we have the results for the 6 to 8-year-old children. And here in the more intensive period, it indicates that if 50% or more of the sessions were attended by the families, there was a significant decline in the percent of the 95th BMI percentile. In the transition period, there is actually a pretty inexplicable correlation here shown between 40 and 90%, that the increase was actually greater in these children that attended more sessions. And I don't have a good explanation for that finding, but I would say that the majority of the families were attending only much less in this transition period, down at about 20% of total. Next slide. And here are the results for the 9 to 12-year-olds. Again, we see in the intensive period that in families that attended 20% all the way up to 100%, a significant change in their BMI status. And you can also see that the change was greater in the children that attended a higher percentage of the sessions. In the transition period, we did not see a relationship. For the secondary outcomes, and these are the results at 3 months. I'm not showing here the second period because we didn't have many significant findings. For ages 2 to 5 years of age, we saw a significant decline in the total difficulty scores in both groups, comparison and intervention. For the ages 6 to 8, we saw a decline in systolic blood pressure in the comparison group. We saw an improvement in the PEDS quality of life in both groups, and a decrease in the total difficulty score in the comparison in the intervention group. For ages 9 to 12, we saw an improvement in the PEDS quality of life, again with both groups, a decrease in the total difficulty score in both groups, and a decline in blood pressure, which was actually greater in the intervention than the decline seen in the comparison group. Next. And so in summary, a total of 549 families with overweight and obese children, 2 to 12 years of age, were randomized into the MEN Catch or the Next Steps programs. As you saw, these were predominantly low-income families, Hispanic and Black. We had an average of 78% retention at 3 months and 75% retention at 12 months. For the age group 2 to 5, men did not differentially affect the percent of BMI at the 95th percentile relative to the Next Steps program. For the age group 6 to 8, the MEN Catch program resulted in a greater improvement in BMI status relative to Next Steps at 3 months, but not 12 months. For the age group 9 to 12, the MEN Catch did not significantly affect the BMI status. Intervention compliance was inversely correlated to the change in the BMI status in the intensive phase. And secondary effects were observed for blood pressure, psychosocial status in both programs. And lastly, so we believe the efficacy of the MEN Catch 6 to 12 program was demonstrated for improvement in the BMI status at 3 months, but not 12 months relative to Next Steps. The efficacy was affected by intervention compliance, emphasizing the need for implementation science research on how best to sustain family engagement in low-income populations to achieve long-term improvement in child weight status. So I'll close there and turn it back to Dr. Holscher.
Great. Thank you, Dr. Butte. So at this time, we're going to open the floor for questions. So if you could type in your question, we will ask the panelist. So I do have a few questions here that I wanted to ask. Dr. Barlow, I know you mentioned that there was a little bit it was more problematic to recruit the children who were aged 2 to 5 for enrollment in the intensive program compared to the other age groups. Could you speculate why, or let us know what the research might suggest for that?
Sure. So we, I think many people have evaluated the discrepancy between a child's weight status and the parent's perception of that. So often parents who have a child who is overweight or has obesity don't recognize that. And actually, studies have shown that they get better at recognizing obesity as the child gets older. So I think when you have a young child, it's harder to recognize that. I think that there is a sense, and again, this is more anecdotal, that extra weight at this point, if they do recognize it, is something that isn't a priority, is likely to be outgrown. And then we did have a high predominance of families who were Hispanic. Many of them were recent immigrants, and so we suspect that the perception that higher weight is associated with good health may have influenced the level of concern about the problem.
So kind of a follow-up to that, what were reasons that the children didn't enroll? Why was there?
Well, in that, in all groups, there was a substantial number of families who simply turned it down or we were never able to reach, even though they had agreed to get more information, which in my view is a passive way of saying they weren't interested. But I think that there's an opportunity for future research to try to identify, to ask more specifically what a family's reasoning was. Other possibilities are things like the challenge of transportation, but one would think that would be similar across the 3 age groups.
Great. Thank you for that answer. So,
Sure.
Dr. Butte, I have a question for you. Why did you select the percent of BMI at the 95th percentile other than more traditional outcome measures that we're used to seeing in obesity trials?
I think there have been a number of publications recently that have shown that the percentiles are simply not responsive when you get above the 97th percentile. And I really, wasn't really time to go into detail into all of that. But the growth reference was never intended to address children above the 97th percentile. And so its actual performance is not very good when you have children in that age range. As I said earlier, we had 70% of the obese children were above the 97th percentile in our cohort. And so it just is not responsive to changes. And so it would really have been misleading. Possibly we could miss the total effect because it's been shown that Z-scores, percentiles just don't move as they should, or to reflect the real pattern when you are dealing in that age, in that BMI range. So I guess I really would refer the audience to 3 publications that have recently come out that were authored by Friedman from the CDC, really describing this in detail for the various age groups.
Great, thank you. We can post links to those too in the follow-up on this. So that
would be helpful.
So there's a question from Richard Switzer. And the question is, were cooking classes or instruction culturally specific? Were classes related to Hispanic foods or just generic American prudent diet? So Dr. Butte?
We worked very carefully. Can you hear me?
Yes.
Prior to actually conducting the RCT, we did pilot studies with the men group for over a 2-year period. And the men staff really did a lot of work in customizing the men program, I would say, for U.S. eating habits foremost, and to be consistent with our dietary recommendations and such. In Texas, we were very insistent that we needed to get the whole program translated into Spanish. So again, the program was customized for the U.S. population and in Texas, really to address the needs of our Spanish-speaking population. In the classes, they were taught by bilingual staff. So when you would bring examples up, they would be culturally appropriate. In the actual cooking classes, we used a program again that drew for foods and recipes that we thought would be acceptable to our audience.
Great. Well, I have kind of a follow-up question for that, to that, Nancy. So were the interventions that were offered in Spanish different in any other respect besides language?
Well, again, I think that in any of these type of programs, there's a lot of discussion between the theory leader and the families. And when you would draw on examples, they would be culturally sensitive to what these families are experiencing. And so to that extent, it wasn't written out, but it certainly would come into play when you discussed issues with the various families we were working with.
Okay, a couple of other follow-up questions. There's a lot of interest in that aspect of the intervention. Did you find that children and parents spoke different languages? And then did you see any ethnic differences in your results?
Yes, there were occasions when only the parent or the caretaker spoke Spanish and the children were bilingual. That was quite common. We also had a lot of families that, although they were bilingual, they preferred to have the program delivered in Spanish because they felt more comfortable, particularly in the discussion sessions. So yes, that does occur. And as far as results, we did not see a difference based on ethnicity per se. We did see one difference when we looked at factors contributing to dropout rates. We did see an ethnic difference there with more Black families dropping out than the Hispanic families. But again, I would really caution any results based on ethnicity, because as you saw, this study was predominantly Hispanic, and we really could have a power issue in really speaking to ethnicity with such a small representation of other groups.
Thank you. So, Dr. Butte, one more question. Were there any incentives offered such that if you came to 50% of the classes, the family received a gift card?
The families were reimbursed formally for attending the measurement sessions. There were 3 of them, baseline 3 months and 12 months. So there was a formal reimbursement that was defined at the very beginning of the study for both intervention and comparison groups. Throughout the program in the intervention group, there were little tokens offered, kind of childlike things offered to the children when they would complete their tasks. We had some other incentives in the follow-up period, for instance, passes to go to the zoo. So we did build in some tokens throughout the program as incentives.
Thank you very much. Dr. Barlow, another question for you is, you noted that there was variation in enrollment by site. Do you have any speculation on why that could have occurred?
So I think there was potentially some variation in how busy the practices were. Some of the practices were extremely busy, and I think that might have had a relationship with less referral. I also think that, again, we had a relatively small number of providers. There were maybe on average 2 to 3 per office. And, I think that there was a different degree of kind of motivation, but again, that's sort of speculation and requires more study. So I think if I move forward in looking at this, I think I would want to spend more time understanding the office systems and try to measure the degree of investment that different providers and also staff have in the study. So those are my thoughts, but again, it's pretty much speculation.
Yeah, those would be interesting follow-up studies to do, where you actually collected more robust data around that to look at determinants of referral.
Well, and I think that what this shows is that there's potential here, right? We've got some practices that had a really high referral, and then even within that, somewhat higher enrollment rate. So if we can understand what it is about those practices, then we can maybe raise the other practices up and do a better job of engaging families through changes in practice behavior.
Thank you. So one last question for Dr. Butte. If you could do the study over or look to future directions, what would you change about the program, or where do you think might be some relevant places to adjust the intervention that would maybe show better results?
Well, I would think of it in two levels. One, the program aimed at the preschool children. We had really disappointing attendance and higher attrition amongst the preschool group. So I think a lot of rethinking of how to get those families engaged is needed. The program is excellent. The program itself was fun. I think the families that did attend really did enjoy it and benefited from it. But again, we had pretty poor attendance. So I think a lot of thought is how to reach those families and get them engaged and have it up higher on their priority list, basically. So we had some ideas of how that might be, but again, they'd have to be tested. We thought maybe if the program was made closer to their primary care provider, with a little bit more emphasis from the primary care system, that this is really important to address this early on. With the older children, it was, again, very popular with that middle-age group. We had our best attendance, a little bit less so in the older group, who are kind of your preteens. And I think in that age group, we were a little bit limited on how many times a week we could offer the program at these YMCAs, and conflicts would come up. A lot of times school-based type of conflicts are the parents had other things they need to attend to. So if the program was offered a little bit more flexibility, that may have helped. We had really pretty good attendance for the first 3 months. I think a lot of thought and effort has to be put in how to sustain engagement in the follow-up period. Again, on average, the attendance was about 20%. And again, we were disappointed, and we tried many things to try to keep the families coming, but it still overall was pretty low. And lastly, I think what was really encouraging from my perspective is that although the effect size was not tremendously impressive, we had a range of effect. We had some children that gained, and we had some children that lost really quite successfully. So I think in our follow-up analysis, trying to look at the moderators and mediators, trying to understand why some children succeeded and others did not do as well, or even went in the other direction. So with a better understanding of those factors, I think these programs can be improved.
Thank you very much. So with that, we will close this webinar. I'd like to thank Drs. Barlow and Butte for their presentations today, and Carrie Doima as well as CDC for funding this project. So thank you very much. We will put an archive of this webinar on our website at msdcenter.org. We will also have some follow-up links as we discussed here today. And then please look for other webinars that we might have at the center. So thank you for attending, and hope you have a good rest of today. Bye now.